Good morning, everyone. Thank you so much for joining us this morning. We're going to talk about the aging eye and just some of the vision changes and problems that we can get as we start to get older. So most of the common things we're going to talk about today: cataract, glaucoma, and macular degeneration. So first, let me show you just a little bit about the anatomy of the eye. So here's the lens of the eye. Now look at this lens. It's completely opaque because that is a 4+ cataract. That's a cataract that's so dense that we don't even normally see cataracts that dense in the United States now, because people have already had their cataract surgery done. The second thing that we'll talk about is macular degeneration. And the macula is just that spot on the retina that's responsible for our clear central vision and our color vision. Also, we'll talk about the optic nerve, and we'll find out why glaucoma is really a disease of the optic nerve. And the optic nerve is really how we see. The eye sends a message through the optic nerve to the brain. So first, let's talk about cataracts. So the lens, it's a clouding of the eye's natural lens. Here's our lens when we're born and when we're young. It's completely clear. But look what happens as we start to get older. The lens starts to get cloudy, kind of like looking through a frosty window pane, or like a fog window on your car when you're driving. What happens is the lens over time, it gets less flexible, it gets less transparent, and it starts to get thicker. So cataracts, the primary cause of, notice that I say reversible vision loss in the United States today. Why reversible? Because with a 10 to 15 minute cataract surgery, that cloudy lens can be removed and an intraocular lens or a lens implant can be placed in the eye in the same place where the natural lens of the eye was. Notice that the lens implant is placed behind the iris, which is the colored part of the eye. So what is cataract not is? It's not a film over the eye. You're not causing it by straining the eye. It can't spread from one eye to the other. Although most people, when they have the cataract surgery in one eye, they see that their vision is so much improved and it's so much clearer that they want to go ahead and have the surgery on the second eye. And it is not a cause of irreversible blindness. So aging, as we said, if we all live long enough, we will all get cataracts. But there are some things that can cause the cataracts to develop at a younger age. And one of them is diabetes, mainly because what happens is when the blood sugar is really, really high, the sugar actually starts to swell right into the lens itself and causes a lot of changes. Say you come in to have your eyes examined and you want to get some new eyeglasses. What happens is if your blood sugar is really high, we give you a new prescription for eyeglasses, and you find out that one time you get your blood sugar under control and back to normal, that those glasses don't work anymore. It's because when the blood sugar was very high, a lot of the sugar actually goes into the lens of the eye. The lens actually swells, and then it'll actually be less swelling and come back to its normal shape when the blood sugar gets under control. So that's why diabetics can get cataracts at a much younger age. Previous eye surgery or injury. Now we're talking about surgery to the eye. We're talking about, or an injury when getting hit by any type of a blunt force object in the eye can cause damage to the lens of the eye. Anything that would touch the lens is going to cause it to cloud over. And prolonged use of steroids. Now I think anyone that's on steroids knows that steroids are a miracle drug. They're a wonder drug. They improve the quality of your life, but there are some serious side effects to continued steroid use, and one of them is the cause of cataracts. Increased glare at night. That's one of the main things that we see with people who are developing cataracts. driving at night, the glare from the oncoming headlights can become so terrible that it's almost impossible to see the oncoming cars. Decreased color vision. One of the main things that patients will always say after they have cataract surgery is that colors are so much brighter. Lifestyle changes. You know, years ago, you would go to your eye doctor and they would tell you that you have a cataract, but they'd say, you know, the cataract's not ripe yet, so you're not ready for surgery. So we don't say that anymore to patients. What we say now is, once you get to the point where you want to do something in your lifestyle that your vision is causing you a problem, that's the time to start talking to your surgeon as to whether it's time to consider cataract surgery. You know, whether it's you can't drive anymore, you have a hobby that you are having trouble with because of your sight, that's when you start talking to your doctor about the surgery. And one of the ways that we can help in the office is by doing a test that's called a functional vision analyzer. What it does is that it'll show you what it's like to drive at night with the glare from the oncoming headlights. And it shows you how it can really make such a big difference in your vision. You know, when you come in to get your eyes examined, normally we will put you in a dark room. We show you these bright white letters on a black background, and we get you to, you know, a really good visual acuity. And you say, well, I'm seeing well in here, but in my real life, I don't see that well. So what we want to do is make sure that we can test this vision functional analyzer so that real world life, especially with night driving, it can really make a big change in the decrease of your visual acuity. And a lot of the insurance companies were actually demanding that, and we send that along so that they see that the vision severely decreases when we put it under normal lifestyle conditions. So when do we recommend cataract surgery? Well, we recommend it when the vision is not clear enough for you to be able to do the things that you want to do in your normal everyday life. It's an outpatient surgery. It probably takes 10 or 15 minutes to do the surgery. It says a local or topical anesthetic. Right now, it's done by a topical anesthetic, which means just some eye drops in your eye. There are no injections or needles anywhere around your eye. They do start a small IV, either, you know, in your hand or the arm, just so to make you more comfortable during the procedure. So it's a very, very highly successful procedure. It has a rate of success into like the 98th percentile. So of course, there's different techniques, different indications for the various types now of the intraocular lenses or the lens implants that we have to offer to the patients. So as we said before, that cloudy lens, there it is, it's removed, and a clear intraocular lens is placed right in the eye in the same place where the natural lens of the eye was. So here's some types of lens implants that are now available to patients. Probably the one that you would see the most is the monofocal lens, meaning that the patient normally is set for a distance so that without glasses, hopefully they'd be able to drive, watch TV, go to movies. And the only thing they would need glasses for is maybe a pair of just over-the-counter readers that they can actually purchase at the drugstore. All that lens is completely covered by Medicare and by your health insurance. Then we have some newer lens implants that can do a little more than just give you that one focus of vision at either distance or near. A multifocal lens implant, kind of like almost like a pair of progressive eyeglasses, where it'll let you see distance, intermediate, and some near vision, hopefully maybe not needing any glasses even for close work for maybe like 85 to 90% of your time. Toric lens implants. A toric implant is a implant that corrects astigmatism. People that have astigmatism usually know it. They were born with it. It's just the shape of the cornea that instead of being shaped like a basketball, it's shaped a little bit more like a football. And if you have a good amount of astigmatism, you know that you've always, it's always been corrected in your glasses or in your contact lenses. One other type of lens, the accommodative lens, it's the crystal lens. That's been out for quite a few years now. And that's, it flexes and changes shape, and it kind of works with the muscles of the eyes. Now with these three lenses, with the multifocal, the toric, and the accommodative, even though the basic surgery is covered by your insurance, there is an extra charge for any of these newer implants. And they can be expensive. I mean, some of them can run up to almost maybe $2,000 for the multifocal and maybe $1,500 for the toric for each eye. But consider that, remember, once you have the surgery and the lens implant, that this lasts for a lifetime. So most people, especially now, you know, the baby boomers, and people don't want anyone to know that they need to wear bifocals. That's how the progressive lenses became so popular. So a lot of people don't want to have to wear eyeglasses, so they will consider spending the extra money to have these newer lifestyle implants put in their eyes. Here's a common question that we get: can a cataract grow back? The answer is no. Most people think a cataract can grow back, but in reality, a cataract cannot grow back. So I'm going to explain it to you, but while we do, here's a nice little picture. And what you could see here is the lens implant. This, you're seeing the edge of the lens implant on both of these pictures. And if you see this little wing that's kind of sticking out here, that's one of the haptics. And the haptics are what just hold the lens implant in place. Because remember, it's not sewn into the eye, it's just held in place by these little haptics. So what happens is the way that the surgeons do cataract surgery in the United States today, I always say, think of the lens of the eye just like a grape. So what the doctor does is he goes in, he just peels away the front surface of the grape, he exposes all the pulp, he pulverizes all that pulp up into tiny, tiny little pieces, and then sucks it out of the eye with ultrasound. Now, what they do is the back part of the capsule of the lens, we leave in place. So remember, they, you know, got the front of it out, the whole middle part, they actually sucked out of the eye, and they left what we call as the capsule in place in the eye. And the reason that we do that is that's a way for where we will put the lens implant. We call it putting it in the bag. So it's always a place for the lens implant to stay secure and not fall back into the center of the eye. Because imagine if there wasn't anything behind that lens implant, and say the patient fell or hit their head, that lens implant could always fall back into the vitreous, which is the gel that gives the eye its shape. So since we don't need that to happen, that's why we keep the capsule in place, and the lens implant sits right there, right in front of the capsule, which was part of the living tissue of the natural lens. Now, what can happen over time? And I'd say in about 80% of people that have had cataract surgery, because I've had cataract surgery myself, and actually my capsule did get cloudy. So what happens is all of a sudden you notice that the vision that was so sharp after the surgery, all of a sudden it's not that sharp anymore. You come into the office, we put some drops, and the doctor notices that that capsule that we left in place has become cloudy. So here's a lens implant. In the front, you can see the lens implant. We're looking right through it. And the back that you see right here that looks like it's cloudy, that's the capsule that was left in place. So we have you come into the office, and what the physician will do is they will use a laser to make some holes right in the center of that capsule to be able to give you your nice clear vision back again. So here's an eye that has the clouding of the capsule, and here's an eye that has had the YAG laser done. Notice that the center is nice and clear again, and yet see how out on the edges it's still cloudy, because they don't want to take that whole capsule away. Remember, we want it to sit there to protect the lens implant. So they just made sure that the center of the capsule gets clear so that you can get your nice clear vision back again. And that's called a YAG capsulotomy. We do it right in the office, put in some dilating drops. It just takes the doctor a few minutes to do the surgery, send you home maybe on an eye drop for a few days. And when you come back for your post-op visit, you'll see a big improvement in the vision. So there is most people think that cataract surgery was done by laser. It was very, very common for people to think that, whereas in reality, it was not. The surgery has always been done by ultrasound. Now, there is a new laser out there that's called a femtosecond laser. And basically what that does, it can help to replace some of the handheld tools that are used at the beginning of the surgery when they go in to just expose that pulp, as we said before, from the grid. But that's it's called a femtosecond laser. You probably would see it advertised out there by some doctors saying that they use it. It is expensive. It adds a bigger cost onto the cost of the surgery. Will it become the wave of the future? Hard to say. The physicians in our practice are all experienced surgeons. They do not use this femtosecond laser or need to. Will it become part of normal practice because maybe physicians now in ophthalmology residencies are learning to do the surgery with this? I guess we'll just have to see in the future, but it's called femtosecond laser, and you might see it advertised. Here's something else that's called aura. Oh, wait a minute. Here we go. We lost our slide. Go back. There we go. Got that one. And now we got this one. Here we go. So this one's called aura, or Optiwave refractive analysis. And this is an instrument that really, really can be helpful once the doctor's in the operating room actually doing the cataract surgery. What happens is after the lens is removed from the eye, the physician can use this piece of equipment called aura to actually look at the retina and determine the total cornea measurements. This is really, really helpful, especially in people that have had LASIK done. You know, people who have had LASIK when they're younger because they were nearsighted. The way that the LASIK is done is that the cornea, with the use of the laser, is flattened to make the cornea a lot flatter so that the patient can see a lot better with having to use glasses. But what this does is then it makes the measurements, the corneal measurements from someone that had LASIK abnormal from what the normal measurements are. The normal measurements, say, are 42 to 45 diopters, whereas people that had LASIK, their measurements can be 36, 38. This comes into play when we're doing all the calculations for the cataract surgery. We need those real measurements from before the patient had the LASIK surgery. So the use of this instrument at the time of surgery can have the doctor see what were the real corneal measurements. And also for the toric IOLs are to correct the astigmatism. Someone that has a lot of astigmatism actually will get a special lens implant that corrects it. But remember, again, that implant has to be set at the correct axis for this astigmatism. And this is how it's so helpful to have the aura in the operating room. And also for LRIs, or, LRIs are limbal relaxing incisions. And really, they're just an incision that we make it at the limbus. The limbus is right at the outer edge of the cornea. And it's really good for mild to moderate astigmatism. So the aura, again, it's a little bit expensive. It might be like $500 in the operating room, but for anyone who has had LASIK or needs a special toric IOL or is having the LRI, the limbal relaxing incision, this is really worth every penny so that you can make sure, and the surgeon can make sure, that everything is exactly in place as it should be. So again, I guess that's enough talk about cataracts, and we can talk a little bit about glaucoma. And you'll see that glaucoma really is a disease of the optic nerve. And as we go along, I'll explain that to you. And it is the leading cause of blindness in the United States, especially for older adults. 2% of the population over the age of 40 actually have glaucoma. And you could call it the silent thief of sight, because remember, with glaucoma, there's no pain with it until you would get to a really terrible end stage. So people can be walking around with glaucoma and they have no other symptoms, so we'll see what happens. So what are here? Let's put here and see what are some of the risk factors for glaucoma. Let me get this slide correct. There we are. So risk factors, as we said, increasing age, African ancestry, family history. The most crucial and the most important risk factor is family history. Anyone with a family history of glaucoma needs to keep up with their regular appointments with their eye doctor and have the doctors and staff be aware that there is a family history. So how do we check the eye pressure when you come into the office? Well, they check it right here with this blue light with a tonometer, and it measures the pressure in the eye. The normal pressure in the eye is between 10 to 21 millimeters of mercury. So remember when we said glaucoma was a disease of the optic nerve? What happens is high pressure in the eye can cause damage to the optic nerve that can lead us to have a visual field loss. So think of someone, if I said the normal pressure is 10 to 21 millimeters of mercury, think of someone who's walking around with a pressure of, say, 30 or 40 all the time. What's happening is that pressure is building up and causing pressure on the optic nerve, which is at the back of the eye. Here's what a normal optic nerve looks like. So this is the optic nerve right here. And in the center, this part that looks a little bit yellow is called the optic disc. And in someone with normal pressure, the disc is small and, not even that noticeable. Look what happens here with someone who has had bad glaucoma. We call this cupping of the optic disc. Notice that the center of the optic nerve, there's the whole nerve. Look at what happens to the center. It's almost completely cupped out. So this is someone that has had serious damage to the optic nerve from glaucoma. It really is an abnormality in the drainage system of the eye, causes this pressure to build up onto the optic nerve. So how do we test when you come into the office? Well, except testing your pressure with the blue light, with the tonometer. One of the things that we could do is a visual field test, the test for any blind spot due to damage of the optic nerve. Now, in the real world, we have an overlapping field of vision between the two eyes. So basically, a patient could be walking around with a visual field defect in one eye and not be aware of it because of our overlapping field of vision. So here's the visual field test. If you've ever had one done, you're looking into this bowl. It's done one eye at a time. You could see that the patient has the other eye taped. And when you look into the bowl, you'll see there's it's full of all different lights. But basically, what we want you to do is there's a light right at the center. We have you look right at the center light the whole time. And anytime you think that you perceive a light to flash on anywhere in the periphery, we want you to hit the light. And you can see it's being monitored by one of the technicians so they can make sure that you're following the directions. And, this could be a hard test, a difficult test for patients. Patients will say, oh, no, not that test again. But there is a learning curve to it. So maybe after the first or second time, you become more aware of what you should do and makes it, a little bit easier. But look, here's the results of a visual field test, what it looks like. Here's a normal visual field on the right eye. Looks what happened over here on the left eye. Any of these spots that are really, really dark show a severe visual field loss from glaucoma. If you look over here on the normal visual field, you notice, look, there's one little area here that looks like there's something wrong with it. And is it a blind spot? And do you know what that is? That is the optic nerve. And the optic nerve is our normal blind spot in the eye. Ever notice now how mostly all of the new cars have these blind spot monitors on them? And that's what it is. Sometimes you could be, say like you're getting on 95 and you're trying to pull out into traffic, and all of a sudden there's a car that's right next to you, but you didn't realize it because you didn't see it, because that car got into our normal blind spot. And that's why on the cars now, they have all these extra little gadgets that are blind, monitors, so that it can prevent you from not realizing that that car is right there. But that's the optic nerve, which is our natural blind spot in each eye. So how do we treat glaucoma? Well, the most common thing we do is we treat glaucoma with eye drops. And we're so lucky because we have so many drops now that some of them can just be used at bedtime, to monitor how the pressure is in the eye. And if it's not working so well, we could always go on to laser surgery. Or here's another reason we could use laser surgery. Say you're in the office and maybe you're like 40 years old and the doctor says to you, I don't like the way those optic nerves look. Your pressure is a little bit high. I want to start you on an eye drop. So the patient says, okay, fine. And say maybe you just have to use the drop at night. And then they'll say, well, for how long will I be using this drop? And the answer is you'll be using it for the rest of your life. So the patient might say, but doctor, I'm 40 years old. Are you telling me that I'm going to be using this drop or drops for maybe the next 50 years? And the answer would be yes. But now we have a laser. We have a newer laser that's called an SLT, selective laser trabeculoplasty. And the nice thing about it is it's a cold laser. A cold laser means that it can be repeated. All the other lasers that we use in ophthalmology are hot lasers and they destroy tissue. But a cold laser can be can be repeated, so that if you have this laser and the doctor's happy with your pressure, and say 6 months or so down the road, they notice that the pressure creeps up a little bit, luckily the laser can be repeated. And what this laser does is, if you think of the space where the fluid actually drains out of the eye, I always say it's kind of like a piece of gauze. And basically what this SLT laser does, it makes the opening in the gauze larger so that more fluid pressure can drain out of the eye. And then, of course, there always is major surgery, but major surgery for glaucoma would only be done in any of the instances where the pressure can't be controlled by any other means. So again, what are the risk factors? The risk factors, again, are family history, again, for glaucoma, as we said, the most serious one. Steroid use, any trauma to the eye, almost the same type of problems that we have with cataract surgery and the risks. There's some studies now that say that hypotension, like low blood pressure, Raynaud's syndrome, people that have that, where their hands in the winter start to turn blue, their hands and their feet from the cold, or even sleep apnea and migraine. Now they're working on studies saying that all these things could be causes for glaucoma. So here's something that's really been a big improvement for us. It's called the eye stent. And look at it, improves the fluid outflow and so can lower the eye pressure in the eye. It's this tiny little stent. Look at it here on a penny, how small it is, or even here on a finger. There's the picture of the stent itself, and it can be implanted into the eye so that there's always a place for fluid to drain out. And the wonderful thing about it is it can be implanted during cataract surgery. It's making a permanent opening for fluid to drain out, and it is definitely covered by Medicare. So that's been a big improvement for us. So again, let's talk about macular degeneration. So again, as we said, the macula, the center of the retina, responsible for our clear vision, our central vision, and our color vision. As we said, all the rest of the retina is responsible for are side or peripheral vision. So the risk factors, again, age, probably anyone over the age of 60, if they're in the office and the doctor is looking at the retina at the back of the eye, can probably see some early signs of some risk of macular degeneration. Race, more prominent in white, especially white women, versus glaucoma, which was more prominent with an African ancestry. Again, family history. I have a big family history of macular degeneration. My mom had the wet, which is the bad kind. I'm one of 5 siblings, and I was able to have some special testing done to see what was my risk. And believe it or not, I came out low risk for macular degeneration. And the study broke it down to say probably 2 of my 5 siblings are at high risk, 2 are at probably just a minimal or regular risk, and I was low risk. So that was really, really interesting. But of course, those types of studies are extremely expensive, and I was just lucky to have it done because of my work in ophthalmology. So look at some of the other risks: smoking, obesity. Again, these things that just, the retina needs a lot of oxygen to exist. Smoking, obesity takes away some of the oxygen and lowers the oxygen flow to the eye. Diet, very, very important. You need to include in your diet fish, fruits, vegetables, nuts, even especially walnuts, fish, especially salmon. So these are all good hints how to make your diet better and decrease your risk of macular degeneration. Again, hypertension, heart disease, again, just it's all because of the decreased flow of the oxygen to the eye. So macular degeneration, what happens? The tissue starts to deteriorate. It's a mild to severe loss of vision. It is not total blindness. My own mom, and here I am in ophthalmology, finally said to me at one day, oh, she had lost her central vision. She said, oh, I didn't realize I still have my side vision. So you never lose the peripheral or side vision with macular degeneration. But unfortunately, you're losing your clear straight ahead vision. So as we said, it's the most common cause of visual loss over the age of 60. And there's 2 types of macular degeneration, the wet and the dry. 90% of people luckily have the dry macular degeneration. 10% have the wet. Wet is the bad one, but wet is the one we can do something about, and we'll talk about that. But here's what macular degeneration does. It causes that blurred or distorted vision right in your central vision. So here, if you look at like this stock exchange paper on a newspaper, you'll see that in the periphery, it looks okay. But look what happens when the patient's looking straight ahead. The central vision is all blurred or distorted, or just like looking at a building straight ahead. The part that you're looking at straight ahead looks distorted. The periphery looks fine. Just like looking maybe at the edge of the door when the door's open and you can see how you see. But to someone with macular degeneration, it looks all blurred. So what does the ophthalmologist see when they look inside the eye? Well, they see these yellow spots, deposits that are called drusen. They could be a sign of the development maybe of early macular degeneration, or they increase the risk for macular degeneration. And unfortunately, if you look at this picture of the retina here, you'll see that here's your optic nerve over here. That looks okay. And all these yellow spots that you're seeing here are the drusen. And unfortunately, where do they grow and where do they congregate? Right in front of the macula. So the macula, which is our best straight ahead vision, is hidden right behind these yellow deposits called drusen. So how do we test for macular degeneration? Well, we can send you home with this simple test that's called an Amsler Grid, and you can do it at home. And it may provide the earliest symptom that the macular degeneration is getting worse. So here's what we do. Here's a picture of the Amsler Grid. So you have it at home, you could put it up on your refrigerator or put it up in a mirror in your bathroom. You need to have on your, looking through your bifocal glasses or have on your reading glasses because you need your mirror to see it. And basically what you're going to do, one eye at a time, cover the other eye with the palm of your hand. You look right at the grid, look straight ahead at the black circle right in the center of the grid. As you're looking at the black circle, and divide the grid into 4, any place where lines are missing, wavy, or distorted. If you have macular degeneration, the ophthalmologist will send you home with one of these grids. When you get home the first time, look at it, see how it looks to you, establish a baseline, and then once or twice a week, look at this grid. The day that you see that this grid looks different from however it looked before, that's the time when we want you to call the office right away and say, you know, that grid that you told me to look at every day or every week, it looks different for me today. And the reason that we want you to do that is because it might have turned to the wet macular degeneration. But first, here's our dry macular degeneration again. It is the most common, and probably 90% of patients that have macular degeneration have the dry. It's just caused by aging and thinning of the retina, which, as I said, is normal, especially as we get maybe older than 60. And how do we treat it? Well, we treat it with nutritional supplements. We treat it with the AREDs too for macular degeneration. Most people are on, anybody with a diagnosis of dry AMD will be on these AREDs too, minerals and vitamins suggested by their ophthalmologist because they will help reduce the progression of moderate to advanced macular degeneration. Okay, so here's the wet macular degeneration. As we said before, that's the bad one, but it's only 10% of people that usually get it. What happens is bad blood vessels start to grow up underneath the macula and then start to leak. Once they start to leak, it can become rapid and severe. It happened to my own mom. She had had cataract surgery a few years earlier, and all of a sudden she said, you know, one day that, you know, my vision is not nearly as sharp as it used to be. So I said to her, well, come into the office. And I was thinking that she probably just needed that little YAG laser because the capsule behind her lens implant after her cataract surgery had become cloudy. So I was going to take some pictures while we were waiting for her to see Dr. Matossian. And when I went to take the picture of the right eye, we couldn't even see the retina. The only thing we could see was blood. And so it had progressed to macular degeneration, the bad wet kind. So how do we treat it? Well, treat it with injections. They used to treat it with laser or PDT, which was a photodynamic therapy. They'll still do some laser treatment for macular degeneration, but in this day and age, most of the treatment is done by injections. So here's what the macula actually looks like. So here's a picture on OCT of the retina. There's the macula right in the center, nice and normal, perfect. Look what happens over here of someone with bad wet macular degeneration. As you could see, blood vessels have broken and then the blood has streamed up, and this, all the swelling that it's caused, this is what it looks like. How do we treat it? They treat it with injections. Some of the injections that they use today, they're anti-VEGF injections, Macugen, Lucentis, Eylea, Avastin, which was an off-label use of the drugs. This drug, Avastin, was actually used for colon cancer treatment, and it was discovered that it also would be a good treatment for macular degeneration. The reason that that's used a lot is we can provide that to a patient for a very minimal cost. These other injections are extremely expensive for the patients, but luckily all of these companies have programs set up for the patients to try to get them into the programs and cover the cost of these injections. But say if the person comes in the first time we're ever seeing them, we see bad, wet AMD, the doctor can actually on that day do an injection of Avastin for them. So they do the injections usually every 4 weeks for a series of at least 3 in a row. There's a brand new injection that's just come on the market called Vabysmo, and it's new and it's less frequent injections. So we'll see how that will be for the future. But we have all this available by our retina specialists in our practices, both in New Jersey and in Pennsylvania. So, would we have good vision, hopefully, as we try, as we grow older and as vision problems do occur, early diagnosis and treatment by an ophthalmologist can help us maintain an enjoyable lifestyle. So thank you very much. I hope you enjoyed the program. And that is it.
I want to thank you very much, Joan, and did a wonderful job. And we have some time now. If you have any questions, you're welcome to put them in the chat box and we can answer those right now. Also in the chat box, I put the evaluation survey. It says Survey Monkey. If you could kindly complete that before you leave today, I will be staying on for a little while, so you'll have an opportunity to do that. And also there is a recording link. As I said, it will be posted probably in the next week or 2. If you had any questions after the program, you could take a look at that site. So we have a first question here. How common is it for a patient to need the YAG laser after cataract surgery?
It's very, very common. I'd say up to 80% of patients who have had surgery will definitely need to have the YAG laser done. Even if the capsule looks a little bit cloudy right after the surgery, the physicians like to wait at least 3 months to actually do the YAG laser. And with other people, it could be even 1 to 2 years down the road, where all of a sudden they'll notice that there's a change and they need to have the laser done.
Any other questions for Joan? How to improve peripheral vision?
Wow, that's a good one. Wow. I don't know about how to improve peripheral vision. I don't think there really is a way. That's really, that's really a tough question. Most people, unless they have some type of retinal disease or problem, have good peripheral vision. As we said, luckily with the macular degeneration, it only affects our central vision. With glaucoma, as I said earlier, you could be walking around with glaucoma and not even realize that you had a visual field defect, because in the real world, we do have an overlapping field of vision.